Hello, this is Ibek Marakimov speaking. I'm one of the cardiac anesthesiologists at the University of Kentucky and also serve as a point-of-care ultrasound director within the Department of Anesthesiology. Today we'll be talking about rush and fast ultrasound protocols. I have no conflict of interest to declare in relation to this presentation. We are going to talk about the indications for both rush and fast exams, review the diagnostic performance, discuss how to perform rush, fast, and e-fast exams, and understand that there is some overlap between the two. We'll review the pathology and finally discuss some of the limitations. So first, we're going to talk about the rapid ultrasound for shock examination or rush. Perform this exam in undifferentiated patient who is hypotensive. It can help you understand the type of shock the patient has, which could be hypovolemic, distributive, cardiogenic, and obstructive. It is important to mention that it was first developed primarily for non-trauma related hypertension and shock. Let's review the history of rush examination. It was first introduced in 2006 as a concept. 1 year later, it was discussed at national scientific meetings, mostly emergency medicine, and in 2008, online protocol was published. It is important to give credit to emergency medicine colleagues who pioneered this practical point-of-care ultrasound assessment. So what about the test performance of rush examination? It has a sensitivity of about 87% and specificity of about 98% for undifferentiated hypertension in the emergency department. We can extrapolate this data to the PACU or postoperative care unit and ICU. On this pictorial, we see one suggested exam sequence with the views needed to obtain to perform a comprehensive rush exam. It is important to note that here on this pictorial, they recommend use of curvilinear probe for all the views, which is possible. However, phase array probe is the best probe to perform cardiac point-of-care ultrasound portion of the exam. And if time allows and considered essential, linear probe is superior for DVT screen or deep venous thrombosis screen as an add-on part to this exam. And linear probe, because of its higher and superior resolution, is usually better for lung ultrasound exam for pneumothorax detection. Please take a moment to review this slide. So what to look for in a rush exam? There's a good mnemonic called HIMAP, where H stands for heart, I stands for IVC, M for Morrison's pouch and splenorenal recess. Another name for Morrison's pouch is hepatorenal recess. A is for aorta, and P is for pulmonary. Please take a moment to review this table with potential pathology next to the organ. So first, we'll start with the cardiac portion of a rush exam. You need to perform and obtain 3 windows, such as parasternal long axis, apical 4-chamber, subcostal view, including the inferior vena cava or IVC. So like I mentioned, it is recommended to use a phase array probe, which is shown on this picture for superior cardiac point-of-care ultrasound. There are different probe manipulations which are important for us to understand. First, ultrasound probe sliding is usually self-explanatory, but means moving the probe along the surface of the skin or tissue. Next is rotating the probe, which means that we move or turn the probe around its central axis without moving it along the axis, such as in sliding, for example. With tilting, we move the angle or adjust the angle of the probe while maintaining the contact with the patient's skin. And with rocking, we tilt back and forth the probe along its long axis, at the same time maintaining the contact with the skin. Please take a moment to review this slide. Let's review the peristernal long axis view first. You position the probe with a probe marker aiming at the patient's right shoulder, left peristernal line, typically in the third or fourth intercostal space as shown in this picture here. Next picture, you see a typical anatomy. And in peristernal long axis view, you typically look at the heart from the base, which means where the mitral valve is, to the apex. But again, normally in the typical classic peristernal long axis view, you don't see the apex of the heart. The next picture is a live image of a peristernal long axis view. Again, please take a moment to review this slide. Next, we talk about the apical four-chamber view. In man, you typically find this view by placing the probe with a probe marker towards the patient's left in the infralateral area to the left nipple. In women, you typically find it underneath the infralateral quadrant of the left breast. And again, like I mentioned, position the marker to the patient's left. Here you see one way how the probe is placed in the man. On this picture on the left, you see a typical anatomy of an apical four-chamber view. And here you see a live image of an apical four-chamber view. Please take a moment to review this slide. Next, we talk about the subcostal and inferior vena cava or IVC views. You place the transducer below the xiphoid process, orient the marker to the patient's left for subcostal view, and orient the probe marker cephalad or up for the IVC view. On this picture to the right, you see a typical anatomy or subcostal view. And on the picture, or actually a movie on the left, you see a live image of a subcostal view. Let's take a moment to review the slide. Next, let's take a look at the IVC views. Again, the marker of the probe is pointed cephalad. Here's a typical anatomy of the view, and here you see a live image. Sometimes it can help you understand the volume status better, especially in extreme circumstances, such as very small or slit IVC, which would suggest the hypovolemic state, compared to an IVC which is dilated and doesn't change much with respiration, which would suggest potentially hypervolemic state, cardiogenic shock, or obstructive shock, such as, for example, tangent pneumothorax or pericardial tamponade. Please take a moment to review this slide. Next, we'll discuss what I call diaphragmatic views, which are both left-sided and right-sided. Right-sided, you want to find the liver, splenorenal recess, and the diaphragm is the right lung. On the left, you normally find the spleen, the kidney, the splenorenal recess, and the left diaphragm and lung. Splenorenal recess can sometimes be more challenging to find, and if circumstances and patient pathology allows, consider a right decubitus position if possible to improve visualization. Again, you can use either a phase array or curvilinear probe. Here's an image of showing you how to position the probe with a marker towards the patient head or cephalad. Here you see the right-sided splenorenal recess. You see the Morrison's pouch, which is a potential space where fluid or blood will tend to accumulate first. And here you see the left splenorenal recess. Please take a moment to review this slide. Remote abdominal aorta. You can use either a phase array or curvilinear probe. You want to screen for dissection or aortic aneurysm, which can sometimes explain why the patient is hypotensive, such as, for example, in case of rupture or dissection. Again, this is how you position the probe. And again, you want to see the celiac trunk. Sometimes you can see renal arteries, and you want to finally scan it and see the bifurcation of abdominal aorta into bilateral common iliac arteries. Again, you slide the probe from the subxiphoid process towards the umbilicus, where you typically expect to see the bifurcation of the aorta. Let's take a look and see how this looks in ultrasound. Here in the top left, you see an image showing you the branches of celiac trunk, such as common hepatic artery and splenic artery in the short axis or transverse view. On the top right, you see the same image, but rather in a longitudinal or long axis view. Here you see further down, and you see a takeoff of bilateral renal arteries. And here you see it further down, where you see bifurcation of aorta into the iliac arteries. Again, it is important for us to remember that a good acoustic orientation for us is a vertebral body. And you can clearly see the vertebral body on the bottom right image and on the bottom left image as well, and also in the top left. Again, use vertebral body as a way to help you find abdominal aorta. Please take a moment to review this slide. Let's take a look and review how pathology can appear in the ultrasound exam. Here on the left, you see aortic aneurysm is a large moral thrombus. Here it's even more pronounced and impressive. And on the image on the right, you see abdominal aorta with a dissection flap. Please take a moment to review this slide. Let's take a look at the bladder views with ultrasound. You can either use curvilinear probe or phase array probe. In pediatric and skinny adults or small adults, you can even potentially use the linear probe, which will give you superior spatial resolution. You want to place a probe above the pubic symphysis, and here you see how a typical bladder will appear in ultrasound. It is important because sometimes free fluid or blood will tend to accumulate in the parabladder space or the space around the bladder. It can also directly suggest you about the volume status of the patient by looking at the amount of urine in the bladder, and also can help you understand whether the folic acid is properly positioned or not. Please take a moment to review this slide. So let's talk about the pulmonary views. Like I mentioned, the linear probe is preferred for this indication. You want to place the probe either in a parasternal location or middle axillary line on both left and right side. Lung ultrasound is all about artifacts. At the top left, you see a typical image of a lung ultrasound. You see ribs with rib shadowing. You see a pleural line. You see A lines, which are reverberation artifacts of a pleural line. Sometimes you can see B lines, which are vertical lines stemming off pleural line. Again, I refer you to our lecture on our channel and review the lung ultrasound in more detail. But again, just to remind you, classical and relatively specific ultrasound sign when pneumothorax is a lung point. Second most important finding, which will suggest rather confirm pneumothorax in a patient, is absent lung sliding. Again, I refer you to our presentation on lung ultrasound for more detail. In some patients, you can extend your rush exam assessment to screen for deep vein thrombosis or DVT. You can use linear probe, which is superior for this indication. And you can consider this in cases of right ventricular failure to screen for DVTs, which will help you understand whether more advanced therapies for suspected massive or submassive pulmonary embolism are indicated. You want to scan femoral and popliteal veins and assess the veins for compressibility and well-formed blood clots. Here's how you typically position the probe to find the common femoral vein. This is how you typically position the probe in the popliteal fossa for the popliteal vein, very similar to how we do popliteal approach to sciatic nerve block. This is how common femoral vein looks, so-called Mickey Mouse sign left tweet, you see a common femoral artery, and the top right, you see saphenous vein merging with a common femoral vein. And here in the popliteal fossa, you see how a popliteal vein and popliteal artery typically appear. Fresh blood clots will typically be anechoic or hypoechoic, so you will not necessarily see them with ultrasound. However, lack of venous compressibility is a very suggestive finding for fresh blood clot. More chronic or well-formed blood clots sometimes will appear hyperechoic and will be easily seen on ultrasound. Let's take a moment to review the slide. So next we'll discuss several cases. All of those cases will have the same patient, but different ultrasound findings. So we have a 25-year-old male who presented to the emergency department with complaints of fatigue, cough, and shortness of breath. His blood pressure after 4 liters of crystalloids is 80/45. He has sinus tachycardia with a heart rate of 155. He's tachypnic with a respiratory rate of 32 and hypoxemic with a saturation of 92% on face mask. You obtained bedside point of care ultrasound. You used rush exam for that. And the next question is, what is your impression? And we'll follow on to the next slide. So let's look at some of the ultrasound images you obtained for this patient. Here is parasternal long axis view. And again, take a moment and pause the video if you want to understand what's going on. So here you see hyperdynamic heart with a very good systolic function. What I mean by hyperdynamic heart is that you see that the walls of the LV are coming together during systole. So you can already exclude cardiogenic component or cardiogenic shock as a cause of his hypertension. So next you look at the inferior vena cava or IVC. Please pause the video if you need to understand this image a bit better. So in this particular view, IVC is kind of equivocal. It's really hard for you to make much of it. It's not really slit, which would suggest hypovolemia, but it's also not really dilated and full, which would suggest an obstructive or cardiogenic shock component. Next, you see a lung ultrasound component of the rush exam. And again, pause the video if you want to spend more time. But here you see diffuse B-line pattern, which are vertical lines, stemming of a pleural line. Then you look at both diaphragmatic views, and you don't see any free fluid in the abdomen and no free fluid in the lungs. So putting this all together, you have a hyperdynamic heart. The patient doesn't seem to be hypovolemic. And the patient has diffuse B-line pattern. So this would suggest to a possible sepsis and pneumonia and distributive shock as a cause of our hypertension. Let's do another case. Again, like I mentioned earlier, it's the same patient, but will have different findings. So you obtained several images. So first, you obtain lung views again, and you have diffuse B-line pattern on both left and right side. Then you fold it with a parasternal long axis view, and this is what you get. Take a moment to review the slide and understand what's going on. So compare this parasternal long axis view to our first patient, who had a very hyperdynamic and very robust systolic function. Here you can see that the LV and the RV are barely moving, which are suggestive of cardiogenic component. You obtain several other views which were unremarkable except for dilated IVC, again suggestive of a cardiogenic shock as a primary etiology. Please take a moment to review this slide. Let's go on to and review the images for the third patient, who again is the same patient but is different pathology and ultrasound findings. So let's review and see what our patient number 3 has. First, you have this personal long axis view. Again, take a moment to understand what's going on there. Here you see that the LVs were decompressed, underfilled, and being squished by dilated and dysfunctional right ventricle. Here you have a personal short axis of the same patient. How do you obtain the personal short axis? You basically rotate your probe from the personal long axis and aim at the left shoulder. Again, on the top of the screen, you see right ventricle. On the bottom of the screen, you see left ventricle. Again, you see the LVs very underfilled and being squished by the dilated and dysfunctional right ventricle. Again, look at the position of interventricular septum, which is so-called D-shaped position of a septum. Why is it called D-shaped? Because it reminds us of a letter D. Here you have an apical four-chamber view, where again you see dilated and dysfunctional RV, or right ventricle, underfilled left ventricle, and you see that the right ventricle is barely moving, except for the apical part of the right ventricle, which seems to be hyperdynamic. This is called McConnell sign, which is relatively specific for acute pulmonary embolism. And then you decided to screen for venous clots, and that's what you see when you compress. On the top right of a DVT exam image, you see common femoral artery, and the bottom left you see a common femoral vein. You see it doesn't really fully compress, and you see there is something floated within the lumen of the common femoral vein, which is a clot. Again, please take a moment to review this slide. Let's see what happens to this patient now with the case number 4. Let's take a look at some of the ultrasound images we were able to obtain. Here's a personal long axis view. And again, pause the video if you need time to understand what's going on. But again, here, like in our first patient, you see hyperdynamic left ventricle, hyperdynamic right ventricle, and a very good and robust function. But then you see that the inferior vena cava is quite dilated. It doesn't seem to change its diameter in relation to patient's breathing or respirations. Then he decided to do a point of care ultrasound of the patient's lung. This is his left lung. Here you see that what we call a pleural sliding or pleural shimmering, where you see pleural moves with respiration. And again, in this particular view, it rolls out a pneumothorax. But then you decide to image the right lung. This is what you see. You see some pleural shimmering, but it doesn't seem to extend towards the other rib, and it stops abruptly. This is called a lung point, which is a very specific sign of a pneumothorax. Please take a moment to read the slide. And again, this patient has tension pneumothorax causing obstructive shock, and he needs to be decompressed from this perspective by placing a needle decompression device or chest tube, whatever is faster. So next, the patient number 5. Again, the same patient, but different findings. And this will be our last patient for rush exam portion. Let's see what you got on your ultrasound exam. First, you obtain an IVC view. You see the IVC is dilated and its diameter doesn't seem to change much with respiration. Next, you got a personal long axis view, and this is what you see. Again, please feel free to pause the video if you need more time to understand what's going on there. You see a lot of anechoic fluid around the heart. You see the RV compression there, and you see that the heart is swinging within the pericardial fluid. This is also seen on the personal short axis view and apical four-chamber view. This case is an extreme example of pericardial tamponade with a swinging heart, which will manifest as pulsus paradoxus on a 12-lead EKG. Please take a moment to review this slide. Next, let's switch gears and talk about focused assessment with sonography in trauma, or FAST, and extended focused assessment with sonography in trauma, or EFAST. It is indicated in patients with trauma. You screen for free fluid, which is assumed to be blood in an unstable trauma patient. Again, as you remember from the rush exam, there is some overlap with the views. EFAST, you add full reviews like in rush exam to screen for pneumothorax. Again, on the right part of the screen, you see a picture showing which views need to be obtained for a FAST exam. Please take a moment to review the slide. So let's review a basic history of the FAST examination. In 1970s, the use of ultrasound was described in Europe to detect free intraperitoneal fluid, and this was adopted in the 1990s in our country and also incorporated in the ATLS guidelines. Again, it is important to give credit to our trauma surgical colleagues and emergency medicine colleagues for helping to advance this exam and practical point-of-care ultrasound in an unstable patient. So what about the performance of FAST exam? It has a reasonable sensitivity for free fluid ranging from 85% to 96%, and it has a very good specificity for free intraperitoneal fluid of approximately 98%. Again, if your initial exam is negative and suspicion is still there, consider a serial exam, unless the patient needs to go to the operating room at the moment. Again, the sensitivity for solid organ injury is unfortunately lower at 63%. Please take a moment to review this slide. All right, let's do a couple of cases. You have a 25-year-old male who has no past medical history. He presented to the emergency department after a fall from the roof. His blood pressure is 80/45. After 4 liters of crystalloids, he's in sinus tachycardia, heart rate 155, tachypnea with respiratory rate 32, and he's hypoxemic with saturation 92% of fluid face mask. Again, you obtained FAST exam, and what is your impression? And we'll go on to the next slide to see the images you obtained. All right, let's see what we got. On this image, you see anechoic free fluid around the liver, and also you see that it's also present in the hepatorenal recess, also known as Morrison's pouch. So again, you already have a positive FAST exam. Then you screen a little bit higher, more cephalad. You see the diaphragm, and you see some amount of right-sided pleural effusion there. Is anechoic fluid around a collapsed lung. You see this on the bottom right part of the image, just above the diaphragm. You also see the spine above the diaphragm, which is not a normal finding because you're not supposed to see the spine above the diaphragm under normal circumstances, because air doesn't really let the ultrasound beam to penetrate that deep. But again, because the lung is collapsed, whether because of a pneumonia, infection, or pleural fluid, like in this case, you can see the spine, which is called the spine sign. Next, you do the same on the left. You see kidney, you see spleen, and you see complex free fluid in the abdomen. And then you scan the bladder, and next to the bladder, you see anechoic fluid as well, suggestive of free intraperitoneal fluid. And again, in this unstable patient after major trauma, this is blood and bleeding until proven otherwise. Please take a moment to review this slide. All right, let's do case number 2. And again, this is the same patient, but with slightly different pathology. This is what you get. Here's a still image of this patient. Again, you see a liver, you see a diaphragm, you see a large complex amount of pleural fluid. Because there is pleural fluid and no lung, because of that, you see a spine sign, and you see what is labeled as plankton sign, which is a hyperechoic complex material within the pleural space, which is suggestive of hemothorax or hemorrhagic blood effusion. Here's a live image where you can see the same, and you see the plankton sign in action, where you see the swirling hyperechoic particles within the pleural fluid, which are suggestive of a hemothorax. Again, please take a moment to review the slide. Unfortunately, no test in medicine is perfect, and point-of-care ultrasound is no exception to this. There are some limitations which are important to review. The performance of rush and fast exam is negatively affected by body habits such as obese individuals, by patient positioning, bowel gas, pneumoperitoneum, pneumomediastinum, operator experience, presence of drains, and surgical dressings. It cannot unfortunately reliably distinguish between hemoperitoneum or hemothorax from non-bloody fluid or chronic fluid, which was present before the trauma. It has limited sensitivity for solid organ injuries such as bowel and spleen. And again, it is important for us to know these limitations, and if time allows and patient circumstances allow, supplement this with other modalities if needed, such as, for example, computed tomography scan. Please take a moment to review this slide. So in summary, fast and rush exams are relatively easy to learn, relatively fast to perform, can be very, very helpful in an unstable, undifferentiated patient who is hypotensive and in shock. But again, like in previous slide was mentioned, beware of its limitations. Finally, I want to thank you for your attention. If you have any questions, please do not hesitate to contact me on this email address provided on the slide. I wish you all the best and good luck.